Hello everyone, welcome to DM Neurology Made Easy. I am Dr. Ahmed Subir. Today we will be discussing regarding AIIMS Neurology Recall Question Series Part 2. As you are aware, previously I had put a video on AIIMS Neurology Recall Questions, a few of them. So in these recall questions, I am not really discussing the questions, I am discussing also the probable questions which would be asked in the future AIIMS, NIMHANS as well as the NEET. And as we know, we had a huge success with the recently conducted AIIMS, just like the previous year institute as well as the NEET exams. And one more good news is that all the mock exams and all the subject wise as well as the topic wise exams as well as the videos which I have been done are being all collected and put in an app format, and which will be made available by May end. So with that, we'll continue with the question. So first question would be from this AIIMS exam: eye of tiger appearance in MRI is seen in which of the following conditions? Is it NBIA, that is neurodegeneration with brain iron accumulation, idiopathic Parkinsonism, Canavan's disease, or Huntington's disease? So you know about eye of tiger appearance, which you must have been learning or hearing from the MBBS period because it's a fancy term. So the answer for this question is NBIA, that is neurodegeneration with brain iron accumulation. So what was the previous name of this condition? NBIAs. NBIAs are of many types, of which the PCAN, that is pantothenate kinase associated brain degeneration disease, which was previously called Hakim-Adams disease, is notorious to have this eye of tiger appearance. And why is that occurring? So you know how to differentiate between these MRIs. So this is actually the flare image. You know the outer gray matter is much whiter and the inner white matter is darker. So as we have known, this is actually a kind of a T2 image, and of which the CSF is much darkened. So this is inversion where the CSF is darkened. So this is a flare image, and this I have told you earlier, this is a T2 image, and this is an SW image or a gradient image, in which there will be darkening only in case of when there is a deposition of iron, paramagnetic or magnetic substance, that is basically blood or calcium. So if you see, you can see there is actually darkening in the basal ganglia region. So this is the internal capsule here. Internal capsule is here. Internal capsule. This is the lentiform nucleus, and this is the caudate nucleus. And the lentiform nucleus, we have the globus pallidus and the putamen. So there is some abnormality there. You can see that. If you see that, you'll be able to make out. So this is the eye of tiger appearance. So here in the globus pallidus region, because of the iron deposition, there will be darkening, and it is just resembling like that of a eye of a tiger. That is why you have the eye of tiger appearance. So why does this occur? Because the eye of tiger sign refers to symmetrical bilateral abnormal low signal intensities in the T2. That is because of the iron deposition. And what is that white thing we see in the middle of this darkened thing in the globus pallidus? That is because of the high signal is due to the basically gliosis and the spongiosis, because of the dead tissues within the iron accumulated region, because the iron is actually kind of destroying the cells within that region. So in the center there will be gliosis and spongiosis that gives the typical what you call the eye of tiger appearance. So if you see, this would be the dark region would be the iron accumulated region, and this white region would be the spongiosis or the gliotic region which we see. So this is actually seen in that is why it is called eye of tiger appearance in case of Hakim-Adams disease or PCAN, or otherwise it is one of the group of NBIAs. So do you think that it is more specific for this disease? No, it is not just specific for this disease. It could be found in other conditions also. Especially it could other deposition of diseases like deposits like especially in Wilson's disease where there is copper deposition. So it is basically paramagnetic and diamagnetic substances. When deposition we can get such kind of appearance there also, because that deposition will result in blackening, and when the tissue gets damaged, we can get the central gliotic or spongiosis. So it can resemble eye of tiger there also in Wilson's disease. And the specific findings in Wilson's disease that I am not repeating right now. Then atypical Parkinson's disease. Some atypical Parkinson's disease can have specific finding, and OPC poisoning also is notorious to have this MRI finding. And also you should know that normal MRI is taken in 1.5 Tesla. But sometimes if you take a high intensity Tesla like 3 Tesla MRI, we can have this kind of eye of tiger appearance in MRI in case of even normal population. So one more sign I would like to say is, this could be asked in your future exams, that's why I have just put it. So usually we get the swallowtail sign. So that is it is normally seen in the subtraction weighted susceptibility weighted image in the case of a normal individual. The swallow like thing, this swallowtail like thing in the normal SW image we see in a normal individual. That is actually swallowtail sign. So when there is an absence of this, when you cannot differentiate between the swallowtail, so it getting fused between each other, is called absent swallowtail sign, and it is now becoming considered to be having a high diagnostic accuracy in differentiating a normal person from a patient with Parkinson's disease or dementia with Lewy bodies. So we don't need to have a dopamine scan or a triad scan to differentiate a patient coming with tremors from with whether he has got Parkinson's disease or not. We can just see a normal SW image to see. So better visualized in 3 Tesla and all, but this can itself get you. So this is actually the absent swallowtail sign. So it previously should have this is the swallowtail. So it should have been like this. So now the differentiation of the two fork-like things of the tail have now lost. So now it has become joined together. So this is the loss of swallowtail sign in. So now Canavan's disease, it's an autosomal recessive disorder, deficiency of N-acetyl aspartoacylase, and it's kind of a leukodystrophy. And the enzyme in myelin synthesis is lost, so there is accumulation of NAA. So there is megalencephaly. So few diseases causes megalencephaly like Alexander's, Canavan's, and Vanderknapp disease. So these are the diseases. So it's kind of a leukodystrophy. So MRI will look like this. So with that, we'll go to the second question. So you must have got few questions, extra questions from the very first question we discussed. So what is the incidence of death in SUDAP per 1000 population? So what is this SUDAP? Sudden unexplained death in epilepsy is called SUDAP. So in 1000 population, what do you think is the number of deaths we expect in SUDAP? So for that, we need to know what is the definition of SUDAP. So the answer for this is 1. And the median reported incidence of SUDAP is mainly 1 per 1000 population according to Medscape. And most of the studies says that it is nearly 1.21, etc. So the correct definition and correct identification is varied from 1 to 5. So I'll take the answer as 1 based on my research on various studies, and the Medscape clearly states that it is 1. And so it is actually a patient having epilepsy has a sudden, unexpected, non-traumatic, non-drowning death with or without evidence of seizures. And you should make sure the patient didn't have a status epilepticus lasting more than 30 minutes. And post-mortem should not reveal any structural or toxicologic cause for death. So that should be the criteria of SUDAP. And there should be definite SUDAP. This usually needn't go further, but you should understand this actually. So no other cause like status epilepticus should be there, and various mechanism has been suggested. Could be cardiac respiratory autonomic dysregulation which is causing this. And with that, 13th question would be, what is the diagnostic criteria used for SSPE? SSPE, that is subacute sclerosing panencephalitis, which is a sequelae of measles. So previously, now it's actually rising because because of anti-vaccine and vaccine campaigns which are going on. This is getting importance, sclerosing SSP, and more cases are now coming up. Patients presenting with mental retardation, difficulty with seizures, etc., with myoclonic jerks, etc., are coming up. So this gains importance, and these questions could be repeatedly asked. So which is the diagnostic criteria do you think is suitable for analyzing SSPE? Is it Dykens criteria, McDonald's criteria, Kurokawa criteria, or Duke's criteria? So what do you think? So the answer is Dykens criteria, and the criteria goes like, it looks into the clinical, the EEG, the CSF, it looks into even the measles antibody, and for definitive diagnosis we have to look for the brain biopsy finding. So EEG, always remember that there is something called Rader-Mecker complexes. So these are stereotyped polyphasic complexes. As you see, there is repetitive polyphasic activity going on, that is repetitive discharges going on at regular intervals, so periodic activities. And for SSP it is called Rader-Mecker complex. So it complexes are lasting 2 seconds, which comes at a regular intervals, take more than 4 seconds it reappears. And there is separate staging called Jabot staging for SSP. You keep in mind that 4 stages are for Jabot staging. And you should know that these periodic discharges, if occurring in child, we will think of SSP, and if occurring in adults, we think of CJD. On another way of thinking is that if there are short interval discharges, that is intervals of between these discharges are occurring less than 4 seconds in an EEG, electroencephalogram, then these periodic discharges are, which occur periodically, are occurring within less than 4 seconds in between these discharges. These are short interval discharges, and these are characteristic of CJD, and which are occurring a long interval. If you see in this EEG, these are actually this one block is actually 1 second, and if you see here, we have got 1, 2, 3, 4, and 5 seconds. So these are actually long interval discharges, periodic long interval discharges. That way I have marked it as PLID, periodic long interval discharges, are characteristics of SSP. Always look in the question, what is the age of the patient also. So if it's a young age patient with EEG similar like periodic discharges, then it is more likely to be SSP rather than CJD. As you know, CJD is an older age disease. And what is this Kurokawa criteria? Kurokawa criteria is a criteria used for one of the conditions exemplifying this characteristic shown in this picture. So these are the features. These are actually telangiectasias, which is shown in this picture. Telangiectasia or mucosa, hands, etc. The disease will be having AV malformation, cerebral malformation, hepatic AVM, there will be bleeding, etc. And there will be inheritance pattern according to that, and autosomal dominant inheritance. So this is actually dealing with HHT, hereditary hemorrhagic telangiectasia, otherwise called Osler-Weber-Rendu disease. Osler-Weber-Rendu disease. So Osler-Weber-Rendu disease. Sorry, I am unable to write properly. Osler-Weber-Rendu disease. So HHT. So that is Kurokawa criteria. So we were discussing about Kurokawa criteria. So Dykens, McDonald's, as you know, it is regarding MS. So we have so that is regarding this thing. The 14th question would be, which one of the following is the drug of choice for SUNCT? SUNCT, you know, it's actually short lasting unilateral neuralgic headache with conjunctival tearing. So SUNCT, conjunctival injection and tearing. Short lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. So what are the drugs which are responsible, which is the most useful drug of choice for SUNCT? is it lamotrigine, verapamil, indomethacin and valproate? So lamotrigine is the answer for this question, and this SUNCT is actually associated with more predominant in males. Mean onset is 50 years. And other drugs which are useful are topiramate, carbamazepine and gabapentin. Indomethacin has no effect at all. There are most of the headaches which are coming laterally are indomethacin responsive. This is one which there is no response to indomethacin. So you should know lamotrigine tops the list. That is the first line effective treatment is lamotrigine. Then only comes the other groups of drugs. And 15th question is regarding Hakim-Adams triad. Hakim-Adams triad is otherwise called Hakim-Adams disease. Is useful in the diagnosis of which one of the following disease? So is it NPH, vascular dementia, Lewy body dementia, or dementia with Lewy body disease? So this is a pretty easy question. So you must have all answered in the recently concluded AIIMS. So this is a combination of dementia, gait disturbance and urinary incontinence, which we call Hakim-Adams triad. And this is characteristically seen in NPH. And this subcallosal ankle, if it is acute, we think of NPH, and if it is obtuse. So this is a most common differential. If you NPH usually is confused with multi-infarct state or age-related atrophy and all. So if it is obtuse, it is most likely to be age-related atrophy or multi-infarct state, rather than that is encephalomalacia occurring due to atrophy, rather than NPH. So this condition is this MRI CT is more likely to be due to NPH, and this condition is due to NPH, and this one is not a case of NPH. So it should be acute, and there are other criteria you should learn regarding NPH. All of the following will cause dose-dependent malformation in pregnancy, except. So what do you think? So most of the studies were done for malformation risk in pregnancy regarding they looked into basically the first and the second generation drugs. So what do you think would be an exception to this? So that valproate is notorious to cause dose-dependent malformations. So which are the exceptions? So is it phenytoin, lacosamide, lamotrigine or valproate? So this is one of the slides which I had taken from talk by Emilia Peruca, who is a famous epileptologist. So this is from the URAP registry regarding anti-epileptic drugs. So all these drugs were the main ones studied, and the best answer for that one is actually lacosamide. Lacosamide is the one which is actually not much studied. But the other three is more likely to be causing dose-dependent malformation, of which lacosamide has less been studied. Maybe future more studies would come regarding the same. And if you see this chart, the valproate, based on the doses, the risk of malformation increased drastically if the dose is increased more than 1500 per day. And if it's less than 700, the risk reduces to just 5.6, and if it's more than 1500, it increases to more than 24.2. So that is the important value you should have in mind. And similarly for lamotrigine, it's 300, and carbamazepine 1000, more than 1000 increases the risk very much. Also in phenobarbital, and also phenytoin also increases the risk. So 17th question, retinal degeneration is not a feature of which one of the following disease? Is it Alexander disease, cocaine syndrome, mitochondrial cytopathy or Krabbe's disease? So what do you think the answer is? So answer is Alexander's disease. Let's know more about Alexander's disease, because it's one of the leukodystrophies. You should know that regarding the importance of pediatric neurology in our exams these days. It's not pediatric neurology that is important. It's just the reason that these diseases, these pediatric population just ages and becomes adult population, and they present with spasticity, seizures, and other features like peripheral neuropathy, etc. And that is why we get more of the questions like that. And also there is importance to pediatrics. So this questions, especially from leukodystrophies, you have to study. So today itself try to revise leukodystrophies. So which are the different types? One, what does leukodystrophy mean? Of which Alexander disease is one of them. So you know it is associated with megalencephaly or macrocephaly. I discussed in the one of the previous slide. It is associated with GFAP gene mutation, glial fibrillary acidic protein mutation, and it is associated with seizures, spasticity, mental retardation, and developmental delay. And you should know one more thing, that it has got something called Rosenthal fibers. And you know Alexander the Great. So think of Alexander the Great. So he led from front. So the leukodystrophy or the white matter destruction will be in an MRI, will be in the front. So you differentiate this MRI. If a MRI is shown to you, you always think in case of Alexander disease especially, this leukodystrophy will be anterior predominant. See here, anterior predominant. So Alexander disease, this Alexander the Great led from the front. That is why he conquered many countries, etc. So things like that. That's a mnemonic I use. Canavan's disease. Actually, this also has megalencephaly. So Alexander's, Canavan's, and one more disease is Van der Naap disease, or megalencephaly with cyst. That is the other name for Van der Naap disease. So those three will be having megalencephaly. So those three will be having megalencephaly or high increased head circumference. So that you should know. Adrenoleukodystrophy, you specifically know, that will be asked. That will be posterior predominant. And metachromatic leukodystrophy will be having periventricular, and there will be tigroid pattern. You can see tiger-like pattern. Then you had one option as cocaine syndrome. So what is this cocaine syndrome? It has nothing to do with cocaine. Just remember, it is an autosomal recessive leukodystrophy where the patient will be having growth failure, impaired development of nervous system, photosensitivity. The patient will be dark with premature aging, just kind of a progeria like thing, and there will be hearing loss, and there will be pigmentary retinopathy. And the patient will be having atrophy in the brain with calcification along with dysmyelination. So atrophy, brain calcification, dysmyelination, this kind of picture, think of cocaine syndrome. Calcification with atrophy, dysmyelination, think of cocaine syndrome. And globoid cell dystrophy is other name for Krabbe's disease. This also will be having retinal degeneration and mental retardation, irritability, stiffness, and seizures. A patient presented with Upgaze palsy with light near dissociation. So what will be the most likely diagnosis? Is it Perinaud syndrome, Maillard-Gobler syndrome, posterior optic nerve ischemia, or anterior optic nerve ischemia? So light near dissociation and Upgaze palsy. So as we know, we had discussed extensively in the 5 neurophilia series stroke sessions, both advanced and basics, regarding the role of 4 by gaze, where we have discussed regarding the brainstem syndromes and how to differentiate each of them. And this light near dissociation and upgaze restriction are characteristic features of the dorsal midbrain syndrome, otherwise called the Perinaud syndrome. And it has other features like Collier's sign, which is delayed retraction, then convergent retraction nystagmus, and the causes varies according to the age group. It could be either due to aqueductal stenosis, or in adults it could be demyelination, trauma, or AV malformation, and it could occur due to posterior fossa aneurysms even. So just see the 5 neurophilia series for such for detailed explanation. So now let's see question number 19. So this is regarding a 19-year-old boy who presented with focal seizures, and his CT showed the following findings. And the options given in the exam were Neurocysticercosis, toxoplasmosis, CNS lymphoma, and cryptococcus. So all these questions would have, all these options would have caused seizures in a 19-year-old boy. So the most probable from out of these would have been neurocysticercosis. I'll tell you why. So for the patient to be having another features like CNS lymphoma, toxoplasmosis, etc., he should have, the structure in the question should have been a immunocompromised patient, most likely. Even cryptococcus, etc., should have been an immunocompromised patient. But neurocysticercosis, it's not needed. And that is one of the thing, that is one of the clue. The other thing is that in this CT you can see that the patient is the CT brain is having a hyperintensity in the form of hyperdensity in the form of ring enhancing line kind of hyperdensity here with a central dot sign. It may seem bit eccentric, so you may think that it is an eccentric dot sign, or it could be an eccentric dot sign which is typical of toxoplasmosis. But you should also know that toxoplasmosis, the eccentric dot sign is usually multiple, and if at all it is present, it will be more in the gray white area, and it will be also there in the deep gray zone, that is in the basal ganglia, that region, and the edema will be bit more, and the number of these kind of things, these kind of eccentric dot signs or this kind of cysts would be more. So this is less likely to be toxoplasmosis because of the structure in the question as told earlier, and also because of the typical presentation. This is actually a central dot sign that is typical in case of neurocysticercosis. And neurocysticercosis, this presentation is typically seen in case of a colloid stage. So the stages are vesicular stage, in which we get only the scolex and the cyst, and the colloid stage we get only the ring enhancement and the edema, and the third stage is the nodular stage, and the fourth is the calcified one. So these are the stages. So I already explained why it is not toxoplasmosis. It's less likely to be because it's not an immunocompromised host, and you have multiple lesions, small lesions less than 3 centimeter, and neurocysticercosis is much smaller lesion than toxoplasmosis. And you should also understand one thing: in neurocysticercosis, this central dot is due to the scolex and not due to the extension of the wall abscess or the cyst wall, etc. It is just due to the scolex. And in case of toxoplasmosis, it is not due to the any scolex or any part of the parasite, but it is due to the extension of the abscess wall or the cyst wall, which causes this eccentric dot sign. And you should also know one thing, that eccentric target sign, that is in toxoplasmosis, is seen only in less than 1/3 of the patients. And what you find is actually a hypodensity in case of a CT. Most of the toxoplasmosis, and mostly it will be in the deep gray matter region. And this will be the most likely presentation in case of an eccentric target sign in case of toxoplasmosis. CNS. 20th question would be: earliest extraocular muscle to get involved in thyroid orbitopathy. So you know the various signs in thyroid orbitopathy or thyroid ophthalmopathy or in Graves' disease. So what do you think is the earliest muscle to get involved? Is it medial rectus, lateral rectus, inferior rectus, or superior oblique? So many questions could be asked from this side of eye movement involvement. So thyroid myopathy or this thyroid orbitopathy is attributed to the inflammation and fibrosis of muscle, and the diplopia is due to a tight rather than a weak muscle. And you know, the inferior rectus is the usually affected muscle, and the patient will be having esotrophy. The eyes would be going medially, followed by the further muscles affected would be medial rectus, superior rectus, and then the oblique muscles. So the mnemonic is: I am so glad I don't have thyroid eye disease. I am so glad that I don't have thyroid eye disease. So I would be inferior rectus, then medial rectus, then superior recti, and the oblique muscle, that is the superior oblique muscle. So you should know one more thing, is that in this, the lateral rectus will be affected last. So my next question would be: so what if a patient has a definite thyroid disease, the patient was having severe esotropia, and then later he was found to have exotropia. Later he developed exotropia, that is the eyes moving away from each other. Previously the eyes were moving medially, that is directing medially, then the eyes moved away from each other, that is he was having a strabismus or squinting in the opposite direction, that is kind of exotropia. So the thing is that the lateral rectus is rarely affected in thyroid eye disease, and the presence of an exotropia in a patient with thyroid ophthalmopathy should always raise the possibility of a concomitant, that is, along with the thyroid disease, the patient may be having a myasthenia gravis. So definitely we have to treat that myasthenia gravis part to relieve him of the symptoms or the impending myasthenia gravis symptoms from disabling the patient. That is a very important point we have to keep in mind. So last muscle to be affected is lateral rectus. First one to be affected is inferior rectus, and if there is exotrophia or the lateral rectus involvement, always think there is a possibility of concomitant myasthenia gravis. We can check this part. Explanation further is there in actually Paul Brace's localization of neurology in third nerve part. So I think this part also would have been helpful for you like the previous part, and most of them part would be questions I know would be useful for you, and explanations are future questions for you. So study that part also. Don't waste your time, especially during this pandemic period. Try to look at the positives and try to read through, keep the momentum going. So all the best for all of you in all the future endeavors and writing the exams and getting a good seat in the DM entrance, especially in neurology. All the best.